Hello, everybody. Thank you so much for being here. I'm Tina Sindher. I'm an allergist at Stanford. Right now, I'll talk about some food allergy facts and what kind of factors help decrease your chance of food allergy and what may worsen your food allergy. So just a food allergy overview. It is a major growing issue. The rate of food allergy has been increasing exponentially over the past couple decades. 6 million children under the age of 18 have been diagnosed with food allergy. And there's a 50% increase in food allergy from 1997 to 2011. So it's a major health epidemic. And then we don't completely understand why. There is a genetic component to it, but it doesn't, genetic predisposition alone cannot explain the rise that we see. And then in 65% who have the diagnosis of food allergy, no parent has it and no other sibling has it. So it's in a family where they haven't had to deal with food allergies before. And then a few other environmental factors that they think protects or hurts them is early environmental exposures are good. So the people growing up in farms or have dogs and cats at home tend to have a lower incidence, or have an older sibling who brings home all the germs. That seems to be helpful. And then children who go to daycare seems to have lower food allergy incidence over time. And it's not, now that we know more and more about food allergy and that there's no real cure, there's a lot of research going on into prevention. So what can we do early on to prevent food allergy from showing up in the first place? So as I mentioned earlier, there is a spectrum of food allergy. So when allergists say it's food allergy, they mean IgE mediated, which means that you have IgE in your body that recognizes the protein, and within 30 minutes of exposure, you have symptoms. So hives, difficulty breathing, angioedema, or lip swelling. And then there's a few kind of mixed type allergic symptoms where you have allergic asthma or atopic dermatitis, where there's a little bit of the IgE component to it, but it can also be other parts of your immune system. And then there's a delayed type where, such as food protein-induced enterocolitis, where people eat the food and then hours later have profuse vomiting and diarrhea, but it's not an IgE-mediated process. So I just wanted to go over wheat hypersensitivities and the different kinds. So there is autoimmune, that's celiac disease. And then there's the allergic wheat sensitivity. So there's food allergy, where after exposure to wheat, you have symptoms that I mentioned earlier, difficulty breathing, hives, lip swelling. And then there is a condition called wheat-dependent exercise-induced anaphylaxis, where people may consume wheat and then if they exercise within 3 hours, tend to have an anaphylactic reaction. So we don't, again, completely understand the mechanism behind it, but it seems to be caused by wheat exposure before they exercise. And then there's a condition called Baker's asthma, where if you have repeated exposure to wheat inhalation, you can over time develop symptoms of allergy. And then we talked about non-celiac wheat sensitivity, where you have all the symptoms, but none of the lab results to confirm it. And then anaphylaxis, so just wanted to touch upon that really quickly. It is when you have preformed antibodies in your body. So the second your body is exposed to that protein, it causes a type 1 hypersensitivity disorder where you basically you may end up with life-threatening hives all over, lip swelling, difficulty breathing, throat swelling, and things like that. And at the first sign of anaphylaxis, epi should be used as quickly as possible, because as I was mentioning before, that is the only thing that can actually stop an allergic reaction, whereas antihistamines such as Benadryl really just kind of treats your symptoms, not actually preventing the release of all the inflammatory mediators in your body. So anyone who has been diagnosed with food allergy or has a family member with food allergy should always have epi on them all the time and be ready to use it if needed. So some of the factors that impact risk of food allergies. So as I was mentioning earlier, genetics can some genetic factors can help or hurt you. And then diet. So the more processed foods you have, more preservatives, that can increase your risk of food allergies. Pollution, recurrent exposure to viral infection, and if you have really bad eczema, that can increase your chances of food allergy. And then chronic use of antacids or antibiotics can also worsen it. And then a varied microbiome helps you. And then the more kind of variety of diet you have as early as possible will also help you. So just to go back on so I wanted to discuss something called the Atopic March. So with food allergy research, there's a lot of effort going into how we can prevent it. And they've found that people who end up with food allergy or other allergic disorders present this kind of atopic march, where initially they have severe eczema, and then later on they present with asthma, allergic rhinitis, meaning seasonal allergies, and asthma. And the term atopic march is used to describe this progression from severe eczema to other allergic diseases. Allergic or atopic dermatitis is a skin disorder. It presents early for certain people, and it's not just that, it's itchy and it is uncomfortable, but you can also get secondary infections, and it really affects your life, especially in children. So that's another thing that has just increased over the past decades. It's not just food allergy, it's eczema. And so this is just a diagram showing how you start with atopic dermatitis and over time develop seasonal allergies, food allergies, or asthma. And even though we think it starts early, it can come on at any point in life. And then they found that approximately 1/3 of patients who have eczema end up with asthma, and about 2/3 of patients who have eczema end up with seasonal allergies. They do know that there is an association between eczema and food allergy, but they don't really know what proportion quite yet. However, in our clinical trials that we do, we see almost 90% of people with food allergy have had eczema in their lives. So it is very common. So the proposed pathway of why eczema might cause food allergy is that when you're young and you have eczema, you have a lot of water loss through your skin, and different allergens can kind of enter through your skin, and then you develop sensitivity through that. So that's how children with eczema end up, being diagnosed with food allergy early, because they've been sensitized through their skin. So when they figured out that eczema might be playing a role, several studies have looked at if you can prevent eczema in the first place, does that decrease your risk of food allergy? So to do that, there were several studies that looked at kind of just moisturizing babies and seeing how that works out. And overall, among many different studies, they found somewhere between 30 to 50% decrease in high-risk patients who didn't end up with food allergy just by treating the eczema early, or preventing the development of eczema in the first place with a lot of moisturizing. And then for people who aren't able to prevent the formation of eczema, aggressive therapy of the eczema early on can also kind of decrease the development into food allergy. So they've done a few studies where they did something called weekend therapy, where kids with eczema, instead of just treating them with steroids every day, just did it on the weekend. And that alone, they were able to control the eczema. For every 2 people they treated, 1 of them did not develop further eczema. And then other studies too, they found when they treated early, they treated aggressively, it just kind of prevents the worsening of eczema and then subsequent food allergy and other allergic issues. So when someone has eczema, they can also get sensitized not just by eating or people eating around them, but just environmental exposure. They find a lot of protein, peanut protein and other food protein in their house, like in their bed, in the carpeting, in the sofas. So when someone has severe eczema, they found that by just very deep cleaning and washing bedding, it reduces their risk of developing food allergy later. And the microbiome, that is another thing that is really being studied right now. And it is now being understood that early varied microbial colonization plays a very important role in developing your immune system. So a lot of studies are kind of out there right now looking at the microbiome and how that can help with food allergies. And then the timing of solids. So even as like 5 to 10 years ago, we were telling parents, don't give peanut, don't give tree nuts until they're at least a year of age, don't introduce fish till they're 3. Whereas now the recommendations are, if they don't have other issues, you start giving them food early, between 4 to 6 months. So with the LEAP study, they found that in children who avoided peanut, they were 5 times more likely to develop a peanut allergy. So currently, they changed the guidelines to say that if someone has severe eczema or an egg allergy, they should get testing done for a peanut allergy. And if they're negative, introduce peanuts. If someone has mild eczema, then introduce peanut around 6 months of age. And if someone has no eczema, no other risk factors, introduce it around 5 months of age. And they've also found to kind of follow up on the peanut, because now they've known that early peanut exposure leads to decreased food allergies. So then they looked at early exposure to a variable amount of foods, and they found that the more foods they were exposed to, the fewer lower their risk of food allergy. So once, I just wanted to touch about the different therapeutic options for people who already have developed food allergy. So the main things right now include oral immunotherapy, where you give people small amounts of food they're allergic to in the hope that you desensitize them over time. There's sublingual immunotherapy, which is the same idea as oral. You just have a tablet or drop underneath your tongue. And then there's epicutaneous immunotherapy, which is basically a patch which has a small amount of the protein you're allergic to, and then you're hoping that your body gets a small amount of that protein through your skin, and then you develop desensitivity. So this is just a list of how kind of immunotherapy started. So it's been around for a long time, only now are we aggressively trying to incorporate it into food allergy therapies. So as I mentioned, with oral immunotherapy, you basically gradually and slowly increase the amount of food that you start ingesting, hoping that your immune system will learn to tolerate it in case of accidental exposure. One of the problems with oral immunotherapy is that it's a very slow process. It can take a long time to get to a maintenance dose, and a lot of people have a lot of symptoms. Every time they take a dose, they have abdominal pain, they have vomiting, they might have hives. So it's really limited by the symptoms that people have. There are a lot of studies going on right now looking at wheat immunotherapy specifically, and a clinical trial just closed and they're analyzing the data. So it'd be interesting to see what they found. Again, a lot of studies are going on. They're also looking at partially hydrolyzed wheat-based cereals to see if that can kind of help with wheat therapy. So with oral immunotherapy, one of the problems is we don't know how long it lasts. Like if you come off the immunotherapy, are you protected? And it really varies from person to person. So right now, the guidelines are you don't come off it. So once you start on immunotherapy, you're kind of on it for a long time. And then the safety concerns, like I said, a lot of people end up with allergic reactions just from the immunotherapy doses. So there's a lot of thought of, is avoidance just easier versus you do immunotherapy and open yourself up to the risk of having anaphylaxis and then needing epinephrine. So a lot of questions we get from patients who are, doing oral immunotherapy, and they ask, will this protect me from ever having allergic reactions again? And we hope it doesn't, but we don't know. And then how long do you have to be on therapy to be successful? For some people, you may have to be on it forever. Will they ever be cured? Oral immunotherapy is not a cure. It's really just teaching your body to ignore it when it comes across the protein. So it's really desensitizing your body to the protein. And then will I be able to eat the food ad lib, meaning as much as I want. For some people, they are able to get there. With peanut OIT, they're able to eat their peanut butter and jelly sandwich. But then for some people, they're never able to get to that point. And really, it's just to prevent them from getting cross contamination and developing allergic reactions from that. And then, is there anything I can do to make it work better? So there's a lot of research going into that. So what other things can we add so that the immunotherapy process is more successful and less painful with adverse reactions? So sublingual immunotherapy, as I mentioned, is the same concept as oral immunotherapy. Instead, you're putting a tablet or a drop underneath your tongue. Initially, it showed very promising results. You have fewer side effects, so more people can continue on. However, it is not as efficacious as OIT. So OIT just works better. And then epicutaneous therapy, we're doing a lot of studies on that right now, where you can wear a peanut patch or a milk patch and hope that you can develop tolerance to those foods over time. You have fewer adverse events, you have fewer anaphylaxis episodes, but these kids do end up with developing eczema where the patches are. But we don't know long-term how efficacious this is quite yet. And the way epicutaneous immunotherapy works is you have a patch that contains small amounts of peanut or milk, and your skin basically absorbs it and hopefully develops, gets desensitized. So those are kind of the mainstream trials that are going on, but there's also a lot of studies looking at how we can kind of target the immune system and get a better outcome. So currently we have a study that's looking at an anti-IgE antibody. So you basically block your IgE, and then you do oral immunotherapy on top of that. So what happens is you can do multiple foods at the same time and not have severe allergic reactions. So you can just get more, you can get through all the foods quicker with fewer reactions. So this seems to be very promising, and we currently have trials at Stanford looking at this. So along the same lines, IL-4 and IL-13 are all part of the allergic cascade. So in asthma, this seems to be working really well. So in food allergy, we're trying to explore whether blocking those can kind of improve your outcome with oral immunotherapy. Currently, we're doing a study with an anti-IL-33 infusion. So IL-33 is another one of the initial triggers of the allergic cascade. So with this infusion, you block IL-33, and then we do a food challenge, and people hopefully we're hoping that they just won't have an allergic reaction. It's not specific to the food, it's just blocking your allergic response overall. And then there's the peanut vaccine. So basically vaccinating, it consists of DNA plasmid of the major peanut proteins, and your immune system picks it up and develops antibodies to it so that when you get exposed to it, you won't have an anaphylactic reaction. And because it's contained inside a membrane protein, your body is not actually seeing the peanut directly, so you don't have allergic reactions to it. So that seems to be very promising, and then that's another study that we're exploring right now. And then probiotics and microbiome. So we're currently developing a protocol where we're adding probiotics with people doing oral immunotherapy in the hope that with a more better microbiome, they'll be able to tolerate OIT better. So there's a lot of studies, a lot of different kind of options, and as we're trying to understand the mechanism of food allergy, we're trying to see not only how to avoid it, but really how to prevent it, and if you have it, can we cure it, and how do we make life easier? So these are the food allergy trials that are currently ongoing at Stanford. So Ivory is a milk formula-based trial for young children, and then we have the anti-IL-33 antibody, and then the vaccine study that I was mentioning, and then we have a few patch studies and oral immunotherapy studies and a Zoller study. We have some brochures out there, so if you want to get more information, you can pick some up at the booth right there, and that's really it. Thank you. I can take any questions if anyone has any.
Any audience questions for Dr. Sindher? Nope. Okay. She'll also be at our booth if you're more comfortable coming over and chatting with her there. So thanks so much. Yes. Oh, Jennifer does.
Do you see very many patients who have both food allergies and celiac disease?
So that's a really good question, partly because with our clinical trials, we really just take food allergy patients. If they have any autoimmune problems like celiac disease or anything else, they're not included. So we don't see a lot of them, but that's partly because of the population we can do the trials on. And in terms of my outpatient clinic, I don't see it that commonly, but not that it wouldn't exist. It's just, it's not very, very, I don't see it that often.
Can you speak a little bit about oral allergy syndrome?
The member asked if talking about a little more about oral allergy syndrome. So when someone has a lot of environmental allergens and pollen allergens, what happens is that there's cross-reactivity with certain fresh fruit and vegetable. So when you eat the food fresh, so not cooked, your body thinks of it as the pollen, and you have oral itching, tingling, maybe a little bit of lip swelling, some throat itching, but it's not an anaphylactic reaction. So it's not going to progress to difficulty breathing, needing an epinephrine pen or anything like that. And the key kind of differentiating factor in oral allergy syndrome and food allergy is that with oral allergy syndrome, when you cook the food, the symptoms go away. Whereas in IgE-mediated food allergy, generally it doesn't matter what form, as long as you're ingesting the protein, you should be having a reaction. A very common reaction is between birch allergy and apple and kiwi and other kind of fruit like that.
People are often surprised that it seems like that food allergies have been increasing in the population over the last few decades, and the same is true for celiac disease. Do they think that there are some overlapping causes there?
So Nielsen and Dr. Kaveri might have more to add on the celiac disease aspect, but from food allergy, what we found that a lot of kind of the changes in our living may be a source of that. So, for instance, increased antibiotic use, increased hygiene. There's a hygiene hypothesis that because our IgE is not out there fighting parasites like tapeworms, pinworms, and all these other things, it just has nothing else to do. So it's fighting, common benign things. And then there's the whole, with autoimmunity and, other conditions that are just rising, such as diabetes, there is a thought that our microbiome might be heavily involved. So our gut is a major source of our immune system. So when the microbiome is skewed, it can't work at its best. So a lot of the rise in autoimmunity and food allergies and just atopic diseases, we hypothesize that our kind of microbiome might be to blame. So more processed foods, more antibiotics, more toxins, all of these things can affect it, and just our diet in general.
Any other questions for Dr. Sindher? Great. Excuse me.
Is it there any differences from the US and the Asia market for food allergy?
There are a lot of food studies that actually do answer that specific question. I don't know the results off the top of my head. There is a theory that, more developing countries may not have a high rate of food allergy compared to developed countries, and it's hard to know because The hygiene hypothesis might help explain that. You may get fewer antibiotics in a country where you may not have access to it, but at the same time, it's hard to get the true numbers of food allergy. Like if getting your next meal is a major concern, they're not out there getting food allergy evaluated. So we actually don't know, in certain countries where they might be impoverished, we don't know the rate of food allergies because they're not getting that evaluated because they have other kind of more pressing issues they're dealing with. But the theory is that because of the hygiene hypothesis, the more clean your environment, there's more allergies there.
Hi. I've been talking to several people today, and they've been asking about, they've been on the wait list for the clinical trials for a while, and what should they do if they're still waiting? Do you have any advice?
So with the clinical trials, we're kind of at the mercy of whatever trials there at that time. So it's not a first come, first serve kind of a registry. It really is, this is the trial that's recruiting. What are they looking at? Oh, they're looking at children ages 2 to 5. So with the peanut allergy. So then we'll reach out to only those people. This is an adult study for 18 plus who just have seasonal allergy to dust mite. So then we'll reach out to those people. So some people may not be have the kind of the criteria that the study's looking for. But if you're ever, if your friends ever have a concern or question, they can always kind of reach out in the registry, send a comment or a question. And I'm sure Julie Bittler is kind of our person who answers all those questions and should be happy to kind of talk about it in detail.
All right, thanks so much. And again, you can chat with Dr. Sindher at our booth if you have any other questions. Thank you for coming.